Hello. So I'm starting a YouTube channel and it's going to be called Conversations with Dr. Khanna. And today I have a very special guest, Dr. Tea Nguyen. She's coming she's joining us all the way from California. And I'd love to just kind of hear about what you do. And can you tell us about yourself, where you're located, your practice, and what you specialize in?
Yeah, I'm Dr. Tea Nguyen. I'm a podiatrist in Santa Cruz, California. I opened my solo practice in 2018, and it's just me and a staff member and like some per diem folks. So I help patients stay active with minimally invasive surgery, give them a lot of options before surgery, but I also do a lot of diabetic wound care as well. And so I also implement preventive minimally invasive surgery. And that's kind of a new thing that's coming around in our neck of the woods.
Nice. All right. So, as most of my listeners know, I'm very big on lower back pain. So I'm very excited to talk to you about a lot of the feet issues that come up with lower back because it's all connected, one big kinetic chain. So a lot of times I get consulted for people who have bilateral feet pain, and sometimes it could just be generalized pain, and sometimes it's just numbness and tingling in their feet. And then they come to me because someone told them it was coming from their back, and I will work up their back to see if it is coming from their back, but sometimes it's not and sometimes it is. So when you get a patient like this, how do you approach it if they have bilateral feet numbness and tingling?
I wish I had somebody like you in my community because I get just as confused because often I get people who have diabetes. And so the immediate thing that comes to mind is peripheral neuropathy. Well, maybe they're just having what we all assume is from diabetes, controlled or not. And my thought process when it comes to complaints about numbness and tingling in the lower extremity is what's most pressing? Is it a circulation issue? So I evaluate for that. And then I start moving upwards. Do you have shooting pain down your butt? Do you have a history of low back problems? Does it hurt when you bend over? Are the symptoms episodic, like every time you sit down or every time you bend over, does it worsen? But oftentimes, at least in my population, it's usually worse at nighttime when they're resting. And that tends to lean more peripheral neuropathy for me because your brain is busy in the daytime, right? So we're not really paying attention to our bodies. But when it gets down to quiet time, you're finally resting and you're almost about to zone out and go to sleep. Your body's like, wait a minute, something happened here. And then it wakes you up and you get the shakes in your legs where you're like, this feels very uncomfortable. And so that's how I approach complaints about lower extremity neuropathy, pain, especially when it's on both sides.
Do you prescribe medications for them, or do you order any tests like an EMG, nerve conduction study, those kind of things?
This is always a point of contention. Like, do I need to work this up further? So the easiest thing is working it up with what we know. If you have diabetes, what's your A1C control? If you don't know, let's get it checked out so I can order those labs. If it's elevated above 7, or even, sometimes we get people who get surprised, they're in the 11s, the 12s. That's the obvious reason for neuropathy. So we work on helping people understand why numbness is happening. It's because of the diabetes control. And so this is a stepwise approach. It's not just, here's a pill, you fix the problem. No, we have to really stop the injury, the source of the injury, which is the nutrition component. And then there are other situations where, like alcohol use, they may not openly admit that it's abuse, but if you're drinking alcohol daily and all of a sudden that becomes kind of part of your normal routine, that's technically abuse. Like, you can't have alcohol, you can't have a day without alcohol. That's a dependency issue. And so I look into the social factors. There may be depleted in certain vitamins. And so we start with what we know. And then if patients are very frustrated and they've tried all the things, I do send patients out for a pain specialist to just have their low back evaluated. Because sometimes I get a lot of farm workers, they're crouching over all the time. Maybe they don't have the best of care as far as prevention goes. Then at least we have some x-rays and imaging and other eyes on the patient to work it up better. For me in my area, I don't have that type of resource readily at my fingertips. It's all in network systems, and it's very, as an independent doctor trying to work within a corporation, it gets very challenging because I can't write those referrals. They then have to go back to their PCPs. Their PCPs have to justify the order. Care gets delayed. And so that's why I was saying I would love to have an independent doctor who can look at the patient objectively and quickly, so that we're not waiting 3 months, 6 months of pain and agony to the point where nerve damage is now irreversible. So that's kind of the process that I have here in trying to work that up. And then I try to work with neurology as well, because neurology in itself, it's so broad. There's neurologists out here who do everything but peripheral neuropathy, or they'll order the EMG studies, the nerve conduction studies, and it shows damage, but then there's really no treatment for it. So they've undergone a painful diagnostic procedure, all to just be told there's nothing more we can do. So that can be really upsetting.
Oh, those are all great answers. I love the fact that you kind of get to the root cause of why they're having the pain. So I love the fact that you order the tests, the lab work and everything like that. That's amazing.
I have a case to share if you want to hear it.
Yeah, sure.
There was a patient who came to me for a second opinion. He had foot pain, just general foot pain. And then he was given gabapentin. You were asking about if I prescribe these medications. Rarely, I try not to. But he was prescribed gabapentin for this unilateral one-sided foot pain around the ankle that was kind of unexplained. And he had poorly controlled diabetes and had numbness in that area. And when I did the workup, it turns out to be a functional problem. It was the shoes tight around the ankle that pinches off the nerve on the top of the foot. So all this time he was taking a medication that was inappropriate because the workup was inappropriate. Again, it goes back to, we kind of put people in places without really listening to them. And I think that's a problem we have in general healthcare spaces when we're dealing with the system versus somebody independent. And so for him, I was able to take him off his medication and just adjusted his shoelaces.
Oh, wow.
Silly, right? Yeah.
That must have been a great feeling that you were able to help this patient.
It's a good feeling, but it's a little disappointing too, because you're medicating somebody who didn't need it. If you just taken another 5 minutes to just listen to the history, you would have known he bought new shoes at the same time he had the symptoms come up. And I think, and the time that we give is what really, really matters.
Yeah, great. Once again, all great points. So yeah, I love that story. I love that you were able to help them. Yes, it is very frustrating when patients come in like that, but at least he did get to you and you did what you could do for that patient. So we just got to broaden what we can provide for all of these patients.
Mm-hmm.
So my next question is about shoe lifts. Again, this is another question I get from a lot of patients. They go to a physical therapist, they get the leg length discrepancy is diagnosed, 1/8 of an inch, 1/4 of an inch, and then they come asking about whether a shoe lift is appropriate. A lot of the therapists do recommend a shoe lift, and I just wanted to get a podiatrist point of view to see how you treat these patients, or what do you recommend?
Limb length discrepancy, most people have it. Now it could be structural because one leg, the bones didn't grow equally for whatever reason, or it could be functional. There may be scoliosis, there may be hip tightness, which is very common. If we're sitting at our desk all day, we're not paying attention to the tightness in our hips and fixing it at the end of the day. Or it could just be, if you have knock knees, your feet will adjust. So there is a small amount of variability that is acceptable as far as limb length discrepancy. So just because I measure a difference doesn't mean I automatically put them in a leg lift, because your body has already adjusted to it. Mm-hmm. But if they have symptoms that is significant enough, like an inch difference, that's significant. 1/4 inch without symptoms, it's hard to justify, because now you're dependent on something that your body had already naturally kind of compensated for. So in all of what I've done so to date, I've only prescribed a lift maybe twice. Okay. And that was because there was a true functional deficit. You can tell the compensation was significant. Again, I work with more patients who have diabetes, and so they have other pressing concerns like losing a leg. So,
Mhm.
I prescribe foot fillers and things like that, or even a prosthetic. So I think it's fine if people are prescribed it. Just recognize that you really need a full picture of what that limb length discrepancy is. Is it soft tissue or is it bone? Because you really need CTs to evaluate to that depth, which is something that I don't order.
Mm. Okay, interesting. Okay, well, that's good perspective because I feel like people do come in with kind of the expectancy, but it's good to kind of get your perspective on that. The expectancy that they would get a shoe lift for the small change and the leg length discrepancy. So my next question was going to be about tendonitis. So I'm a sports and spine doctor, and I see a lot of chronic tendon issues. I do treat Achilles tendonitis and also plantar fasciitis. But by the time I see the Achilles tendon, they're so far gone. They're very scarred and they're thick. And I do a procedure called percutaneous tenotomy, and where I go in and I clean out the scar tissue with a needle. Now I'm very limited on what I can do with a needle. And then if I can't help them, I usually refer them out to the podiatrist to take a better look. So do you do percutaneous tenotomy, or do you, how do you treat like these like hardened Achilles tendons that are very, very difficult to treat?
Well, first, I'm going to ask you later on my show about how you treat Achilles tendonitis because I've never done it with a needle. So I'm really interested because it makes total sense to do it. But of course, I get nervous around the watershed area. So,
Of
how do
course.
I treat Achilles tendonitis? It depends. Is it insertional and causing calcification at the insertion? Or is it mid substance where there's not enough blood supply in that area already? And
Right.
now it's weakened and degenerated. So, it really depends on the level. If it's at the insertional level, and we've tried physical therapy, we tried the heel lifts, we tried all of these more conservative options without relief, I advanced to minimally invasive surgery. Traditional surgery is creating an incision about that big,
Mhm.
opening up, filleting out so we can see the Achilles tendon in its full length, removing some of that scar tissue, detaching that Achilles tendon from the bone, shaving that bone down so it's smooth and removing all of that calcification, and then plugging that tendon back in with some anchors and some sutures, and then you sew them back up. I used to love this procedure because I got to see all of the anatomy. And sometimes I would have to take out the flexor hallucis longus to augment the damaged tendon. So I have like it's just really cool to see this anatomy. I actually really miss it. But since I've transitioned into minimally invasive surgery because people want a faster recovery time with less complications like scarring, hardware rejection, and pain, I've converted to minimally invasive surgery where all I need to do is resect the bone bump to decompress the Achilles tendon. Now, it doesn't look pretty on x-ray. You're still going to see that calcification, but their symptoms are gone. So that's how I treat insertional Achilles tendonitis, is really addressing, again, the source, which is the bone pressing onto the tendon.
Okay, interesting. Okay. That's I'm definitely going to do some more research on that. Yeah, so I focus more on the actual tendon, and you focus on getting rid of the bone that's causing the tendon to be painful. So
Yeah.
interesting. Yeah, and I'd love to talk more about the percutaneous tenotomy, which kind of brings up my next question is the plantar fascia. So I'm sure this is very common in your field, is seeing a lot of
I
plantar
think it's in
fasciitis.
everyone's field. Primary care handles it, everybody.
Right.
Yeah.
So so can you just, I mean, just love to hear it from a podiatrist. What is the plantar fascia and why does it get inflamed?
Yeah. So the plantar fascia is that connective tissue that attaches at the bottom of the foot from the heel, and then it spreads out to the toes. It's a really thick structure, and it supports all of the other structures underneath it. Plantar fasciitis has often been misdiagnosed for other things like a nerve entrapment or even plantar fasciosis, which is degeneration of the tendon, not so much inflammation. It's gone past that acute phase, and now it's just kind of like whittling away. So those two diagnoses are really important to understand because the plantar fasciitis, which is the acute phase, where you step down out of bed and it hurts real bad, or you're sitting in a chair and then you stand up and you feel tightness and sharp pain in the heel, that can be treated with physical therapy, better shoes, maybe custom orthotics, and just general body awareness and weight control. Those are kind of like my push for acute plantar fasciitis. I don't push for steroid injections in this area as much anymore. That's how I was trained. But I've seen that if the patients can commit to routine daily exercises, they can get really good results without injections. Now, if we're talking about plantar fasciosis, where there is degeneration, we can do manual therapy just to increase sensory awareness. And then I also have shockwave therapy. We used to do amniotic injections before they took it off the market, and that has some really nice results. Of course, you have to be very patient selective on who you do these certain therapies on. And so that's kind of how I address it. Conservative, natural ways is stretching, strengthening, supporting it, and then prevention. Some people just have jobs that requires them to stand 10, 12 hours a day. All of our mailmen, all of our UPS drivers, everyone delivering, more and more Amazon boxes to our door, they all have heel pain. So it's really a functional problem at that point. Like, you need to take breaks. There's no shoe that can keep you on your feet for 24 hours, unfortunately.
Right. Yeah, all great points with the plantar fasciitis and fasciosis. So I also have done percutaneous tenotomy on the plantar fasciosis as well. We go in and clean out the degenerative tissue, and I've had some very promising results. So I agree, the steroids kind of were kind of the old way of doing things with all the plantar fasciitis. But yeah, sometimes I'll offer one, sometimes I will send them to you for a podiatrist to take a look. But it's very common. So I'm also curious as to, like, what other sports injuries do you see mostly? Like, what do you like to see as far as sports injuries?
I see a lot of patients with diabetes, and diabetics are athletes too. They want to stay active. And so that is kind of because diabetes in itself, people feel like it's a death sentence. I really love talking about it. Like, no, you can actually live fully with diabetes. You just have to know how to manage it. And you just have to manage it more than somebody who doesn't have diabetes. So I really like taking care of patients with diabetes because they have a couple of things that are unique. Number one, their biomechanics change with time with their diabetes because their tendons actually get tighter, which means they have to work a little bit harder to stretch and remain flexible, because tightness all around the foot and ankle can result in deformities like hammer toes or crossover toes, toes that do that instead of that. Or bunions deformities can be accelerated because now they've developed flat feet and so on. And so because of the complexity involved in all of the tendons that is surrounding the foot, that's what I really like to pay attention to. And if they have hammer toes, usually that's the first reason why somebody would develop a corn or a callus, which is thickening of the skin. And that is when, if it's ignored, it can progress to an open sore, an infection, amputation. So it's a whole series of things that if we catch and educate early enough, just to be self-aware of what your body looks like and what's going on, then we can deal with it quickly. Because in my fellowship training, it was all diabetic foot care. We were catching them at the late stages where they didn't even know they had diabetes, or they didn't know how to control it, or they didn't have the support, or they didn't know they had a deformity. They thought that's just what their feet looks like, or they thought the surgery had to be invasive to correct, so they avoided the doctor overall. Whereas in reality, it's like now we have this minimally invasive procedure that I do percutaneously in the office to straighten their toes to help prevent those amputations. That's the education component that I love to give, because it seems so benign, like, oh, it's just a hammer toe, right? It's just a callus. I can just go to a nail salon and get it shaved off, not realizing your body is telling you something. Something's abnormal. It might be your tight shoe, but it might be aging, and it might be your diabetes and so on. So that's kind of where I work with diabetics who want to remain active and try to give them options that give them lifelong healthy feet, really, so that they can continue to stay active.
Nice. Okay, very good. So one last thing I would like to discuss, as we're almost out of time here, is your practice model. So you're in a direct specialty care model. Can you tell us what that means, and tell us how you track patients, and just tell us kind of all about the new future of medicine?
So you might have already heard me gripe about the system, how it's very like corporate medicine is nothing what we ever dreamt medicine would be. There's a lot of um, stuff that's unnecessary between the doctor and the patient. You know, you have to get permission to get paid. You have to justify your orders. Doctors in this model are having to push out patient appointments because they're so full. And they're so full, their attention is divided because now they have more responsibilities. They have to bill better. They have to use coding. They have to chart. They're charting after hours during family time. It's insane. And so you wonder why your doctor looks pissed off in the morning, right? We're tired.
Yeah.
So I was in that system and I was like, this is not okay. It's unsafe. The more patients I see, the more medical mistakes is bound to happen. Patients are frustrated. They're like, I waited so long to see the doctor just to have the doctor barely even look at me, didn't bother touching me. And now I have a medication that I don't really understand. So they're pissed. I'm a patient myself and I get pissed. I'm like, why did I wait so long for just 3 to 7 minutes of your attention? I deserve more than that. And so that's when I started to decide to really, there's really no winning the system. It's like gambling. The house always wins and they win on purpose. I had to just opt out entirely. So my practice, I don't bill insurance, which allows me more time with patients. That means patients are getting complete care. That means I have my undivided attention. That means I'm not staring at a computer, putting in codes and just like not look, they're looking at the back of my head. No, I'm eye to eye with my patients. I'm touching, I'm watching them walk. I'm giving comprehensive care that can last up to an hour. And it's complete care. And that way they don't have to leave looking for another opinion because I've answered all of their questions. Of course they can if it's out of my scope or if they feel unsure, but direct care has allowed me to be with patients and to give them the care that I believe is right. Or we work on something that, you know, that is in line with their beliefs versus giving care that insurance is requiring us to do. Isn't that strange? We're allowing insurance who don't have medical degrees tell doctors what they can and cannot do for patients. I think that's just ridiculous.
I
So
agree.
now,
Yeah, completely. It's become a checkbox system. Did you check this? Like, did the patient do this? Did the patient do that? Like, we've completely lost sight of the actual patient care right now. So I completely hear what you're saying, and I am dealing with the same issues. Is that, you know, the pre-authorizations. I'm sure you're also frustrated or done with doing prior authorizations, I should call it.
I'm very done.
Yeah.
Yes.
And the denials, and then the lack of payment. And then at the end of the day, the insurance can just say, we're not going to pay you. And then patient, basically we're working for free. And I think a lot of patients don't know that part of healthcare is that the insurance can deny the claim because they just don't think.
All the time. They can also approve your prior authorization. You do the surgery and then they're like, I changed my mind. We're going to take that money back. And if you don't pay it, you go to collections. Yep. Oh, you missed our mail. Too bad. We're taking our money back anyway. That just happened to me. Somebody, an insurance company sent me a letter saying you owe X dollars amount for overpayment. Now you're going to collections. I'm like, I never got a piece of mail. Wouldn't you think that is like certified mail? I don't know. But instead I got sent to collections and I was like, this is why I'm done. Every time I get a piece of letter, I'm reminded why I opted out. And it was hard. And I had to go through some of my own challenges in that. I had to tell patients why I opted out. And I had to like sell to them that this is a damaging system when we all see it, but we're having to like re-educate. And it was exhausting. So I was like, no, let's just make it easy. You want my time. I want to take care of you. And that's the transaction. And you get better care.
Yeah, that's great. I love that you're doing that. I'm in a very similar model myself. And so basically, you know, we're all on the same page as doctors about how frustrated we are with the system. So I just want to thank you for your time for coming on today. This was amazing. Any last words you want to tell us about anything foot related or anything?
Oh, this is to be continued.
To be continued, of course.
We haven't even touched on custom orthotics and my issues with them.
Okay. So interesting. Okay. We will definitely
continue.
Yeah, we'll definitely. This was so much fun. We'll definitely have to do another episode. I know there's so much more that we can talk about that's related to the lower back and the feet and how it's all connected. So join us next time. with Conversations with Dr. Khanna, and I will most definitely have Dr. T on once again. So thank you so much and have a good afternoon.